So, ladies and gentlemen, I hope you had an enjoyable lunch break, and now we are back here with the first symposium in the afternoon. I'd like to thank very much Concept Medical for supporting the session, and I think is really exciting because we are going to discuss here a new generation DCB approach with a sirolimus coating for peripheral vascular disease. I think certainly something which is, has a lot of promise for the future. So I'm very happy here to be with Shai Parikh, who is going to co-moderate with me the session, and we have Thomas Seller, Jos van den Berg, and Dr. Dani on the panel. So for now, I would like to ask Dr. Parikh to speak about the role of sirolimus-coated balloons in peripheral vascular disease.
Dirk, thank you very much. It's a privilege to be here, and I want to thank Concept Medical for their kind support for this session. My name is Shai Parikh from Columbia University in New York City, and I'm going to start the session by talking about the science behind the nanolute technology of the sirolimus-coated balloon. These are my disclosures. I think it's well known to everybody here at LINC that PTA provides reasonably good short-term results, but has a high rate of TLR with restenosis, as much as 50% at 12 months. Nitinol self-expanding stents and other stents have been developed to solve this problem, but also are plagued with restenosis, and therefore drug-eluting technologies have come to the fore to try to improve long-term patency. Challenges with using implants, of course, relate to the risks of stents with stent fracture and thrombosis, particularly being problems even today with drug-eluting technologies. So there remains a desire to leave no metal behind, and therefore using drug-eluting technologies has been in the news, as you probably are aware. The use of a drug-coated device is particularly attractive when there's homogeneous drug transfer to the vessel wall, so that you can avoid chronic inflammation of polymeric release systems on drug-eluting stents and reduce the need for dual antiplatelet therapy and other anticoagulants, as well as improving deliverability to distal small vessels. To date, all of the commercially available drug-coated devices or drug-eluting devices use paclitaxel, which you might have heard has stirred some controversy in the past 12 to 24 months. And so there are some challenges with paclitaxel, which I think you're probably already aware, and you'll hear about some of this from my colleague, Dr. Finn, who's going to follow me. But certainly paclitaxel is known to be a cytotoxic drug, as opposed to the mTOR antagonists, such as sirolimus, which are cytostatic drugs, and therefore potentially less toxic with a better therapeutic window. There's also been, as you know, the specter of mortality associated with paclitaxel, which I won't belabor. And so there has been really a wonder in the field why we're not using limus analogs for drug delivery in the peripheral vessels. There's a number of factors that are particularly important, but one of the major factors that is important with respect to the inability for vendors to develop limus-coated balloons has been the difficulty to encapsulate the drug and then coat the balloons with the drug and make a combination device that can effectively transfer the drug to the vessel wall. And so that's been the real challenge to date. I think the use of limus agents has been well established. Certainly as a coronary interventionalist myself, all of the devices I use in the United States today are limus analogs, and there's been a number of clinical trials randomized head-to-head against paclitaxel-eluting devices that have demonstrated superiority in terms of efficacy as well as safety of limus agents. This is one of many such analyses. So again, as I pointed out, the big challenge in the periphery for the delivery of sirolimus has been the poor lipophilicity of sirolimus, which correlates to its difficulty in adhesion to the balloon surface. And this results in poor bioavailability, and particularly when it comes to the bolus delivery of the drug, when you have poor adhesion and poor bioavailability, you have a lower steady state concentration of the drug in the vessel, which results in lower efficacy. So in response to this challenge and this unmet clinical need, the Magic Touch balloon by Concept Medical has taken a novel approach at the drug coating technology. What the nanolute technology is really the conversion of a sirolimus raw drug into submicron-sized particles that are encapsulated into a phospholipid biocompatible drug carrier. Once the balloon is inflated at the target site, the carrier is transferred to the vessel wall following a diffusion principle. Once at body pH, the drug carrier mimics the body lipids and liberates the sirolimus into the vessel, resulting in both specific and nonspecific binding that will then allow for deep penetration of the drug into the vessel wall. This is sort of a cartoon that depicts what the phospholipid drug carrier and the sirolimus particles look like when combined, and what the balloon surface might look like in cartoon form when spray-coated with the drug-eluting device. Again, these features that are particularly important are the concept of a nanotechnology, structure of the combined drug and elution excipient, if you will, that biomimics the carrier and reduces the size of the overall particulate for better uptake. The drug itself is encapsulated in a native phospholipid that provides protection to the drug during transit and transfer. And then there's a biphasic release kinetics where you have early high rate of release and then more gradual uptake and retention with a pro-healing effect of a limus analog drug. Some of the advantages of the technology developed by Concept include this very smooth scanning electron micrographic appearance of the drug and the biophospholipid combination on the balloon itself that results in effective drug transfer. More importantly, as you're well aware, in preclinical studies, there's a relatively low efficiency of drug transfer from paclitaxel-coated devices, resulting in only 1 to 10% of the drug on the balloon being transferred into the target vessel, with 90% lost in the systemic circulation. Using the unique Magic Touch coating technology, there's a substantial amount of drug on the balloon, and much of it is hidden from the circulation, and therefore resulting in better tissue uptake of the drug. So to summarize, the nanolute technology has made it possible to deliver a sufficient payload of sirolimus into the tissue to inhibit intimal hyperplasia. The technology increases bioavailability of sirolimus and also lowers the in-transit drug loss, which is prevalent in current paclitaxel-coated balloons. And this technology allows the drug to penetrate more deeply into the tissue and generating higher tissue retention and subsequent efficacy. Thanks very much.
Well, thanks, Sahil, and I think we continue with some, let's say, preclinical insights. Dr. Alok Finn, he's going to speak about, basically insight from preclinical evaluation of the Magic Touch balloon.
Dirk, thanks, and thanks to Concept for inviting me to give this talk today. These are my disclosures. So what makes a good DCB? I think DCBs are here to stay. There's just no question. You must deliver large quantities of drug within seconds. Obviously, you have a short amount of time to deliver that drug during the time of balloon inflation. It must distribute quickly within the media within the first few days. You must get therapeutic and sustained drug levels for more than 4 weeks, really to cause inhibition of restenosis. You must allow rapid healing as compared to DES. You don't really want to have long-term antiplatelet agents needed. You really want to get the healing characteristics to be optimized so it heals fairly quickly. And of course, you want to deliver that drug without losing it downstream to non-target tissues. As you all know, these are the drug-coated balloons available for peripheral artery disease currently, and you can see they all share one important characteristic. They're all paclitaxel-eluting balloons, which is somewhat of a lower hanging fruit because it's easier to get paclitaxel into the wall and make it stay there, as we'll discuss. But the newer generation, such as Concept, is introducing a new drug or an old drug with a new use. As you know, sirolimus is used almost standard in the coronary drug-eluting stents, and paclitaxel lost favor after first-generation drug-eluting stents because of inferior vascular responses. Sirolimus is a cytostatic drug, as Sahil pointed out. Paclitaxel is a cytotoxic drug, which really causes cell death, cellular necrosis, whereas sirolimus really is not associated with cellular necrosis or cell death in particular. You can see this best in this nice experiment done a number of years ago where paclitaxel was loaded in different doses onto stents, and the vascular response in an animal model was checked. And you can see as the amount of paclitaxel was increased, the neonatal area went down, so there was an anti-restenotic effect, but the amount of fibrin went way up, and what you started to see is you started to see cell death within the vessel wall. Medial wall cell necrosis is a common side effect of paclitaxel, especially as you increase the dose. So why is sirolimus better? Well, they both inhibit restenosis somewhat to a similar degree, but the therapeutic range of sirolimus is wide. You can use it and have wider levels without getting toxicity, whereas paclitaxel is very narrow. Its safety margin is 100-fold versus that of sirolimus 10,000-fold. Its anti-restenotic impact of paclitaxel is probably not as good as sirolimus. Late loss was not as good for paclitaxel-eluting stents versus sirolimus-eluting stents. Sirolimus has strong anti-inflammatory properties. Those are also beneficial. Paclitaxel has no known anti-inflammatory beneficial properties. Of course, the problem with sirolimus is getting it into the wall and making it stay there, whereas it's much easier to do that with paclitaxel. And we all know the meta-analysis that a year ago was published that caused so many problems, and probably one of the lingering problems was that paclitaxel's safety record is somewhat uncertain, and people are sort of scared of unknown side effects. I don't think there's a real mechanism for the increased rate of death in this meta-analysis, but maybe that's what made it catch on. So sirolimus-coated balloons, what do we need to do to make them happen? Well, we need to enhance immediate tissue absorption. We need to get that sirolimus into the tissue wall. Some sort of instant glue is required. We also need to extend the sirolimus drug release from some sort of depot so that it lasts over 30 days. So Concept's medical solution, as Sahil discussed, is this nanoparticle carrier, phospholipid carrier, which encapsulates the sirolimus and transfers it to the vessel wall and causes sustained release of sirolimus. And you can see that in this preclinical study in the swine iliofemoral model where we use the extreme touch balloon 3x dosing versus a control balloon in pig femoral arteries and euthanize them at 28 days. And what you saw was increased drug effect. Now, we don't look at restenosis here because this is a low injury model. We're looking at signs of drug effect, and that could be indicated by proteoglycan replacement, collagen score, muscle cell loss, both depth and circumference were both greater for the Magic Touch balloon versus the control balloon, showing you successful and sustained drug delivery with this system. What about an in-stent restenosis model? We created a model in the pig where we basically put a bare metal stent in at day 0. We come back at day 28 and treat that neointima with a drug-coated balloon, Magic Touch 1X, or overdosing with 3X, or a POBA 1X or 3X. And then 28 days later, we evaluate the stent to look at inhibition of restenosis or new neointima formation. We can also do PK studies on this type of situation. And this was the pharmacokinetic data. You can see that quickly the blood concentrations of the sirolimus after using the Magic Touch went down quickly and were below detectable at 33 days. And drug levels were detectable using both the 3X and the 1X balloon in the DCB-treated section at 28 days, showing you sustained drug release, successful drug release, whereas the proximal and treated section didn't show anything. More importantly, the downstream areas of treated myocardium, that is the area downstream of the treated segment in terms of the myocardium, didn't show any drug levels. You can see all those levels were below the limit of the quantitation, which was successful drug release to the target without getting unwanted drug release in place you don't want it. Whereas organs also showed the same effect. Basically, everything didn't show any organ didn't show any levels of detectable sirolimus with the exception of the liver, which had very, very low levels of sirolimus. And in terms of the drug effect, again, we see the Magic Touch 1X and 3X had more proteoglycan score, more muscle cell loss, and fibrin than the uncoated 1X and 3X balloons, showing you successful evidence of drug transfer at 28 days in this restenosis model. And what about new neointimal growth? Well, this is a tricky model because you have the existing neointima and you can look at new neointimal growth. And when we looked at that, we isolated to the DCB 3X, the Magic Touch versus POVA 3X, and you can see there was significant suppression of new neointimal growth no matter which way you analyze it. New neointimal area, neointimal area over IEL, or new to total neointimal area. So in summary, I tell you, neointimal hyperplasia is a major cause of restenosis. Pharmacologic agents used on DES and DCB mainly inhibit muscle cell proliferation. The most common used antiproliferative agent is paclitaxel, although we all understand its limitations now. Recent meta-analysis obviously concerned a lot of us about the safety of using this drug-coated balloon with paclitaxel. The Magic Touch Sirolimus DCB has a novel coating technology allowing better tissue retention of sirolimus and capability of anti-restenotic effect, which is seen in our preclinical models. We really didn't see we saw minimal non-target organ drug levels were observed, as I showed you. I think Magic Touch will emerge as an important non-paclitaxel option for peripheral and coronary intervention. So thank you for your attention.
Thank you very much, Alok. So the next speaker is Dr. Choke. He's going to speak about some next trial projects, including the future SFA and future BTK randomized controlled trials.
Thank you. Thanks very much for the invitation. It's a privilege to be here. My disclosures, I have none. So Ecstasy First-in-Man clinical trial is designed to investigate the efficacy and safety of the Magic Touch sirolimus-coated balloon in both SFA and BTK lesions. It is a non-randomized, all-comers single-arm trial. 50 patients were recruited, and the primary endpoint was defined as primary patency at 6 months, defined by duplex peak systolic velocity ratio of less than 2.4, performed by a core lab, which were blinded to the fact that these were trial patients. It is a single-center study. The final patient was enrolled in November last year. The full 6 months data will be available in April next year. And so this is an interim analysis presentation. The key inclusion and exclusion criteria are fairly standard for any drug-coated balloon. Of note is that this is an inclusive trial, including patients from Rutherford's 0 to 6, any lesion in the leg up to the proximal 200 millimeters of tibial arteries. 55 patients were screened. 5 patients failed screening because of inadequate vessel prep to receive the sirolimus-coated balloon. 50 patients were enrolled. This is primarily a CLI cohort, so the percentage proportion of patients with diabetes were high at 90%. It is a high-risk cohort. 1 in 5 patients were already on dialysis. 1 in 4 patients has had a previous recent myocardial infarction. Assessed by the anesthetist independently, the ASA scores in the majority of patients were 3 or more. In terms of the Rutherford scores, because this was primarily CLI cohort, over 90% of patients had Rutherford scores of 5 and 6. Majority had poor prognosis for limb salvage according to the Wi-Fi scores. More than 50% had Wi-Fi score of 4 or above. In terms of target lesion location, the sirolimus-coated balloon were applied to BTK arteries in the majority of patients. And the total length of sirolimus-coated balloons were quite long for both FEMPOP and BTK arteries. A significant number of patients had occlusions and were required to perform retrograde access in order to get a successful wire crossing in about 36% of patients. In terms of 30-day outcomes, there was 1 death and 1 major limb amputation because of severe sepsis in the foot. Device and technical success were both 100%. In terms of the 6 months data, 1 patient had to be withdrawn because of a fractured leg in the same leg. 1 patient missed the 6 months visit. 8 patients had not yet reached the 6 months milestone, leaving us with 40 patients, of which 35 patients completed their duplex scans. 5 patients reached the endpoint of death or amputation and therefore did not receive duplex. This is the primary endpoint, which is a 6 months primary patency. When you look at the whole group, the 6 months primary patency was 80%. Subset analysis of the SFA group was 88%. BTK was 74%. Just for comparison, I've included the data from the recently reported single Pacli BTK RCT, which was performed in Singapore, where the 6 months primary patency for the paclitaxel arm was only 40%. So a 6 months primary patency for the magic touch in BTK arteries of 74% is highly promising. In terms of freedom from TLR, in the whole group, this was 89%. For the SFA, this was 94%. BTK was 85%. In terms of safety endpoints, this is defined as a composite of 30-day mortality, absence of 30-day mortality, absence of 30-day limb amputation, and absence of 6 months TLR. And this was 85%. There were 4 deaths in 6 months, 3 of which were from ischemic heart disease. Amputation-free survival was 88%, and limb salvage rate was 98%. In terms of Rutherford scores, there was a 6 months clinical improvement. The proportion of patients with Rutherford score 5 had reduced significantly by 5 months, suggesting that the majority of wounds had healed by 6 months. The proportion of patients with Rutherford not correspondingly had increased to 83% at 6 months. There was also sustained 6 months increase in toe pressure from 54 millimeters mercury to 77 millimeters mercury at 6 months. So to summarize, the XOC study showed that the Magic Touch sirolimus coated balloon have promising efficacy and safety for both SFA and BTK. And this was the first demonstration of efficacy for BTK lesions for sirolimus coated balloon. There was no distal embolization and no slow phenomenon. And there was no flaking associated with the sirolimus coated balloon, the same flaking as sometimes you would see with the paclitaxel balloon. In my experience, when I use paclitaxel balloon, I've always had concerns with distal shedding and the slow flow phenomenon. This was a case I did about 3 years ago for an in-stent occlusion for the SFA, successfully atherectomized with a jet stream device and angioplasty, and you can see brisk flow down the SFA. However, after application of a paclitaxel drug-coated balloon, you can see the slow flow phenomenon, which I've somewhat come to expect sometimes with a paclitaxel. So my main question with the sirolimus, Magic Touch sirolimus drug-coated balloon was whether there was any similar concerns with distal shedding and slow flow phenomenon. This is an 82-year-old gentleman with diabetes and hypertension with extensive gangrene of the 4th toe. Because of the extensive gangrene, we felt that it was imperative we revascularize both the CTOs in the anterior tibial artery and the posterior tibial artery. Because of financial constraints, we were only allowed to use 3 Magic Touch balloons, so I chose the anterior tibial artery as the balloon to receive the sirolimus coated balloon. And in retrospect, this formed a nice internal control using the posterior tibial artery to see if there was any distal shedding. So this is the initial below-the-knee angiogram showing the CTO in both anterior and posterior tibial arteries. And this is the foot run showing that there was distal reconstitution in both the dorsalis pedis and also distal posterior tibial artery. For the anterior tibial artery, we were successful in achieving antegrade access down to the dorsalis pedis. This was dilated using a non-compliant 2.5 millimeter balloon for below the ankle, followed by a 3 millimeter POBA for above the ankle, up until the origin of the posterior tibial artery. And this is the end result following the application of the POBA, showing a reasonable flow down the anterior tibial artery, down to the dorsalis pedis. And usually at this stage, prior to the availability of the sirolimus coated balloon, this is where I would normally stop. However, since the sirolimus coated balloon has been available in our center since 2017, I've started using it for BTK lesions. And with increasing confidence, I've been able to use it for even below the ankle. And this is one instance of it where the 2.5 millimeter Magic Touch PTA was applied to the dorsalis pedis, followed by a 3 by 200 millimeter Magic Touch sirolimus drug-coated balloon to above the ankle, down to the entire length of the anterior tibial artery. So at this stage, we went on then to try and revascularize the posterior tibial artery. Antegrade approach was unsuccessful. We required to use a retrograde approach in this case. Successful crossing down to the medial plantar artery in this instance. Use a non-compliant balloon, 2.5 millimeter below the ankle, followed by a 3 millimeter POBA for above the ankle, up until the origin of the posterior tibial artery and the tibial peroneal trunk. And this is the BTK angiogram following the application of magic touch to the anterior tibial artery and the POBA to the posterior tibial artery. And as you can see, the flow of blood down both arteries were reasonably similar with no slow flow phenomenon. Similarly, just up to above the ankle, the flow was pretty similar for both the sirolimus treated anterior tibial artery and the posterior tibial artery. And in the foot, we were unable to detect any evidence of any distal embolization. So where do we go from here? In my mind, we do need level 1 data for a larger population. So in Asia, we're planning to run 2 randomized controlled trials for both the SFA and BTK, pitting the magic touch sirolimus coated balloon versus POBA, future BTK and future SFA. This is going to be a double-blind study, 2 SCB to 1 POBA enrollment, involving 17 sites at the moment, 3 countries, CRO control, core lab duplex, planning to enroll in Q2 2020. Thank you very much.
Well, thank you very much, Dr. Chok. So we need to go on with the next presentation, and then I would like to ask Dr. Tan. To speak about outcomes of sirolimus-coated angioplasty balloon in the treatment of dysfunctional AV fistulas and AV grafts.
Thank you. Thank you. It's an honor to be here. I'm a nephrologist in the business of intervention. This is to share the outcomes of sirolimus-coated balloon in the treatment of dysfunctional AVF and AVG. This is my disclosure. A functioning dialysis access in the form of AVF or AVG is critical to the delivery of life-saving hemodialysis patient. These are man-made structures that are created for the sole purpose of dialysis, but what man creates, nature will take back. Neointimal hyperplasia occur frequently within the dialysis circuit, resulting in poor flow, obstruction, and thrombosis. And this is the typical feature that we see in the upper arm radial cephalic fistula with neointimal hyperplasia causing luminal narrowing. And this is how it looks like in an AV arterial venous graft, where there's stenosis predominantly at the graft vein junction. Histologically, what we do see is thick neointimal hyperplasia that is occluding the vessel lumen. And the situation is worse in patients who requires AVG because they have poor native veins for AVI creation. In this group of patients, they suffer from poor primary patency from the AVG because of neointimal hyperplasia at the graft vein junction. And they frequently thrombose, and even after successful salvage with thrombolysis, we are looking at a very dismal patency rate of 49% at 3 months, meaning that half of them actually comes back within 3 months with another event. And at 6 months, 38% were only patent. And in our center, where we try to improve the outcome with paclitaxel-coated balloon in this small retrospective series, we noted that the yield that we can get after applying paclitaxel to the graft vein junction after successful thrombolysis or AVG were only 43% at 3 months, which were dismal. And therefore, when we look into it, when we realize that sirolimus-coated balloon has been successfully used in coronary intervention in small vessel disease and in-stent stenosis, we hypothesized that the application of sirolimus-coated balloon at the graft vein junction after successful endovascular salvage of thrombosed AVG will be safe and effective. And therefore, we undertook a single-center prospective pilot study of 20 patients who presents with thrombo AVG, where we successfully salvage it endovascularly, and then we apply the sirolimus-coated balloon at the graft vein junction. Our primary endpoints were the primary patency rate of the AVG at 3 months and 6 months. A total of 37 patients were screened, and first patient was recruited in October 2018, which gave us a follow-up period of up to 2 years at this point in time. The last patient was actually recruited last year in September 2019. The 17 patients were excluded because they had coexisting central vein stenosis. Some of them had residual thrombus which could not be removed endovascularly. There were 3 who actually failed thrombolysis, and 1 had stenting that was done. So essentially, these were 20 patients who had undergone successful thrombolysis with no residual stenosis. And this is the patient characteristic, 20 patients, median age of 68, with a predominantly female population. Average vintage of dialysis is about 31 months, with a vintage of AVG about 14 and a half. Most of these AVG were created in the upper arm, 75% were brachial axillary AVG. The thrombolytic agent used in the salvage was TPA, accounting for 65%. We used high pressure balloon, usually up to 7 mm in size, and in 20% of the time, cutting balloon were needed to achieve a complete no residual stenosis at the end of treatment before the application of sirolimus coated balloon. And on the average, majority of the balloon used was 7 mm in size. The primary patency rate at 3 months was 65%. The primary assisted patency at 3 months was 80%. The reason for the failure were recurrent thrombosis in 3, and there was actually 1 patient that had low flow that required intervention. Of note, there were 3 patients that were lost, one due to death, one due to explant from a secondary infected AV8G, and one had a revision done for pseudoaneurysm, which were all valid reasons in a dialysis cohort who are undergoing dialysis through an AVG. Therefore, if you exclude these 3 patients, the primary patency rate will be much higher than that, is 65%. If you look at the Kaplan-Meier techniques, where we use it to look at the projected estimated primary patency, this is a primary patency rate of up to 283 days. If you look at it in median terms, it's 381 days. Very, very impressive data, which we could not achieve currently with uncoated balloons. Neither could we achieve that with paclitaxel coated balloon in this distinct cohort of patients. Therefore, at this junction, we felt that the treatment of with sirolimus coated balloon at the graft vein junction after successful salvage of thrombosed AVG appears to be safe and effective. And if you compare the 3-month primary patency rate, it appears to be superior to both plain balloon angioplasty and paclitaxel. And after being encouraged by these initial results in the thrombosed AVG, we went on to apply the arterial venous to apply the use of balloon angioplasty in AVF. We started a registry of 30 patients who undergo successful balloon angioplasty with sirolimus coated balloon, and the requirements was adequate treatment with standard plain balloon before application of sirolimus coated balloon, and this patient were followed at 3 and 6 months with clinical parameters and ultrasound scan. This was the breakdown of the fistula. There were a total of 30 patients. Majority of them were radiocephalic fistula, and brachiocephalic account for about 33%. In terms of location, majority of the stenosis were within the juxta anastomotic segment, accounting for about a third of them. Some were within the cannulation zone. So although there were 30 patients only, there were about 41 lesions that were treated in total. And if you look at the circuit patency, we're looking at a primary patency of 3 months of 96%, which is very impressive. And there were actually 1 patient that required intervention due to high venous pressure and dropping access flow. About 9 patients has reached 6 months of follow-up at this point in time, which gives us a primary patency rate of 89% at this point in time. If you compare these results with what is published in the meta-analysis back in 2019, we can see that in terms of paclitaxel, we're looking at a 3-month patency rate of 92% and a 6-month patency rate of 73%. So the patient that were treated with sirolimus appears to have a similar, if not superior result compared to paclitaxel. At this point in time, in the interest of time, we've been given only 7 minutes to present this. We will conclude that application of sirolimus coated balloon at the graft vein junction in the dialysis access circuit and in AVF appears to be safe and effective, and larger randomized controlled studies are actually required to verify our findings. With that, I will end my presentation. I'll be happy to answer any questions.
Yeah, thank you very much. And that's certainly also a very interesting future indication. I think now we are ready to go to the first life center, to Jena. Yeah, so we can see you, Dr. Aschenbach. Can you hear us now?
Okay.
Yeah, perfect.
Yes, I can hear you perfectly, and me too?
Yes, absolutely. This time
you hear me?
works well. Yeah.
Okay, perfect. In concerns of time, a short introduction. Kathleen is with me to assist the intervention. We have, we can jump to the case slides. We have a 66-year-old male with a PhD stage 2B, Fontaine, left more than right. And he received in December last year a patch plastic of the femoral bifurcation right, and is doing well until now. And what is remaining now is the left side. You can see the index is 0.7, quite bad. And we have a multi-segmental stenosis on the proximal and middle SFA. The next slide, please. You can see here the runoff angiography from 11-19 with these multiple stenosis proximally and a short segment occlusion of the popliteal artery. And the next slide, please. We have planned puncture growing and a 7 French crossover sheath, a pre-dilatation with the POBA, Armada 18, and then the DEP PDA with a magic touch balloon. If needed, of course, a bailout stenting. We can switch to the live screen. We have done some Peripheral steps. This is the inflow of the left leg. You can see an occlusion of the internal iliac artery and somewhat busy situation in the proximal part. Show you later to figure out where is where. This is the proximal SFA with a stenosis, multiple segments proximally over a distance about 10 to 12 centimeters. Even a short stump occlusion of one branch of the deep femoral artery. If you go further down, you can see the next stenosis in the adductor channel and begin of the occlusion segment. If I delete the subtraction, you can see it's in the P2 segment. Further downstream, we have this occlusion, retrograde filling via the collaterals, and we have a outflow, 2 vessels, tibial anterior and the peroneal artery, and a short stump of P3. So we figured out what is the right anatomy of the femoral bifurcation. It was quite difficult, a little bit confusing, but we have it. This is the anatomy now. You can see it goes immediately after the bifurcation. We have these stenosis. And then we tried to cannulate with a guide wire. It was quite simple. We have a support catheter, a quick cross. You can see the fluoro capture. We go downward. It's no problem, easier than we expected. And the wire here inside is a Terumo guide wire 0.35. We change it later to the needed 0.18 guide wire. So this is the second stenosis, no problem. And then we are in the popliteal segment. And now the guide wire runs primarily into the true lumen. That's very important in this segment. And we can place the wire then in the right distal portion. That is to confirm that we are inside the right vessel. You can see now the upstream, a little bit tiny vessel in the peroneal artery at the first branch, and perhaps we will see it in the control scans then in the first segment of the anterior tibial artery, and quite good downstream to the foot. So what we've done right now is we placed, because I am not very comfortable with this situation near the bifurcation, we placed the second wire. So where are the images? We placed the second wire, as you can see here in the fluoro, in the deep femoral artery to have some kind of a live wire, a lifeline wire, yeah? Because instead there are any dissection or anything else. This is a 0.14 wire that we have placed. So due to the technical problems, we have already prepared the vessel with a POBA dilatation for 1.5 minutes with a Armada 18 balloon, 6 atmospheres pressure, and now we are ready to go to dilatate the segment with the Sirolimus balloon with the magic touch. It's still on the wire, and we have a 7 French sheath. And now we are placing the balloon at the dilatation area of the POBA in the proximal segment of the SFA. You can see I have a marker here. You can see the marker? No. This usually the marker. This is the bifurcation, and this is the point where we have dilated. So this is the same position as primarily. for the POBA dilatation, and now we perform the Sirolimus dilatation. I think you heard a lot about the technology, and I have a personal call with Manish Doshi from Concept Medical, and we talked a little bit about the mechanisms of the balloon. So due to the time concerns, no more information. What is recommended is a 2-minute inflation time to give the nano-sized particles the opportunity to transfer into the vessel wall. As you heard, these particles are very small, 0.35 microns. So they penetrate deep into the vessel wall until the adventitia is reached and function there as a reservoir. So, es kann mal ein bisschen drücken, ja? So, recommended inflation pressure is 6 atmospheres. And now we are starting our stop clock to have a 2-minute contact time. So this will give us time for first question to the case.
Yeah, so
any questions from the panel?
Absolutely. I mean, you showed us already a lot of steps. I mean, first was the wire crossing. So distally, the occluded segment, the short occluded segment, so the wire flew through relatively easy, I would say. So is that at all a concern for you, that you're thinking about some fresh material in that location, or do you think it's chronic?
It's not quite clear. I think we will see it perhaps later. It's only a short segment stenosis, maybe, and we have a no-flow area. And I don't mention that there is any material in that area.
Are you think
because we have a prompt retrograde feeling?
Yeah, you think it's only a flow phenomenon and not a
yes.
Yeah, not
yes.
a true occlusion.
Yes.
Okay.
Yes.
Okay, good.
Yes.
Well, back to the dilatation now here. I mean, it looks, at least in the image which is just on the monitor, that in the very proximal centimeter, so the balloon is a little bit underinflated with the 6 atmospheres. Do you think you can also go to higher pressure? Or?
Yes. Yes. As you can see, when I inflate the balloon, I reach always the 6 atmospheres. Mm-hmm. And the pressure drops. That means the vessel responds to the dilatation. But I will be very, very, let's say, patient to do not harm the vessel in that area by means to get a dissection, because we have then a problem with the bifurcation. That's why I had the second wire in deep femoral. But I think it's quite fine. We will see when in the control angio if it fits.
Did you see the same problem with the POBA? Did that inflate entirely?
No. That inflates promptly and harmonic inflation of the balloon.
What is the size of the DCB?
Maybe I can go.
Is it the same as the pre-dilatation balloon, or is it 6?
It's the same. It's the same. Both balloons were 5 millimeters.
So it's definitely not oversized. It's probably even undersized.
Yes.
Yeah. So
that's maybe the case, but in that special case, we can go upward. There's no problem, but I won't start too big or too large in the diameter. So we have now approximately 2:45 inflation time. I will deflate the balloon. This is very promptly, as you see. Works well. Also, the inflation works very well. And I retrieve the balloon a little bit so that it's in the shaft, and we can perform a control angiogram to see what we reached until now. So, es kann jetzt mal warm werden, ja, nicht erschrecken. Bitte ganz still liegen. So, okay, good. So, as we see, we have a promptly downward flow. I guess there is no area with a dissection. Even in the first image, it looks relatively quite good. What do you say?
Yeah.
well, if I compare the diameter of the common femoral with what you achieved at the origin of the SFA, it seems that there is still a residual stenosis. So it's a kind of bifurcation lesion here. It seems more pronounced now that the deep femoral is also stenotic. So your intention or your idea to implant or to position a guide wire here was obviously correct, but wouldn't you now proceed with a kissing balloon? You have a 7 French sheaths in place, so you could probably use your 14,000 guide wire here for a kissing balloon procedure in order to open better this bifurcation lesion, which is obviously present.
Yes, but it's a little bit about the sizing. I would do the deep femoral approximately with a 4 mm balloon. Wir können mal den 4 mm Armada nehmen and go back to the 5 mm Armada for the SFA and see if it fits in the 7 French shaft. Yes. But from the handling of the Sirolimus balloon of the Magic Touch, it's very easy, very similar to other DEB balloons, and the response to inflation and deflation is very good. Even if this is a 120 mm balloon, it deflates quickly.
And there are no concerns with the post-dilatation of the treated segment with the DCB, just like with paclitaxel. Pharmacokinetically, there's no difference in that respect, no risk of blowing off the sirolimus from the vessel wall with the post-dilatation?
No, because I don't know if you heard in a presentation, the folding technology is that nearly 100% of the sirolimus is under the surface. If you push the catheter to the target lesion and only by inflation, it opens up the sirolimus carrying surface so that there is quite under 5% loss on the way to the lesion in comparison or in comparison to the paclitaxel.
And it stays there after the inflation, no risk of washing that off with the second balloon. That's what I meant.
Now, the drug transfer is very rapid, and so you shouldn't have a problem with post-dilatation.
Yes. We have an inflation time of nearly 3 minutes, and the drug transfer, as colleague said, is very rapid, so I'm quite not afraid of to wash off the sirolimus now with the second POBA PDA. Yes. But so placing the first over the 0.18 wire. So I'll go a little bit higher to have a good overlap. And now the second over the 14. Dann brauchen wir noch ein zweites Manometer dann. Ja. So, hast du den zweiten Ballon, den Armada? Den 4 mm Armada? So, okay, we had a quick change, the balloons. So it was a little bit mistaken in the communication. I had the 4 mm balloon now on the SFA, so it happens. We're all a little bit excited. So we change it rapidly, no problem. So, dann hätten wir gerne noch mal jetzt den 5 mm Armada.
So, would anybody have prepared the origin with some kind of scoring device or atherectomy? It looks very much calcified here.
Yes, this is right. It's calcified, and this lesion is. We don't have it's prepared this lesion with atherectomy or anything else. Yeah. I think in the long run, he will have a benefit from a patch plastic too. The goal was to restore the outflow of the SFA even in the occluded segment of the popliteal artery and the downstream. Maybe you can do this as a hybrid intervention in the angio suite. Kannst du noch mal deflatieren?
Sahil, what?
Another alternative. I mean, certainly in our experience in New York, this is a good application of the IVL shockwave technology. So pre-dilatation with shockwave would affect both dilatation and vessel preparation, and then you can lay your drug in with a drug-coated balloon. Atherectomy also can be done. It's a little bit more challenging when you're in a bifurcation, but certainly any of the calcific debulking techniques would be applicable here.
Yes. I think lithoplasty will be a good idea, but we are not having this on stock. because in Germany it's not that easy to have a payment about the insurance. The reimbursement is not clear for that application, but you're absolutely right. When you have it on stock, you can try this to make the vessel some kind of smoother for the PDA, to break down the plaques. So, okay, we are in a good fashion, but we have to push a little bit, see if it can we push it out. But I think the 7 French is not, no. I can't go any further with the second balloon, so we have to do it in another way. So it don't fit the 7 French for both balloons. Kannst du hinten mal ein bisschen schieben, dass wir den Draht nicht verlieren? Okay, so. Okay.
So, I mean, what's the opinion on the panel? Do you think it needs to be dilated simultaneously, or, I mean, my impression was that, I mean, there are
we can
two
do
lesions,
it,
two lesions close to
incremental.
the osteum, but not really fully involving the osteum. So,
No, sequential dilatation would be reasonable here, and certainly the preservation of brisk flow in the deep profunda is what you really want. So I think if you post-dilate here in the SFA, that'll probably be sufficient. Yeah, another way to affect simultaneous kissing here would be to use monorail balloons with the vessel diameters that you're dealing with. Coronary balloons would be easily applicable, and you could easily get those through even a 6 French sheath if you had 2 monorail coronary balloons.
Yeah.
I think
So I
if you,
place now the balloon in the deep femoral, and we do it in an incremental way. As you see, it inflates properly. Maybe this is not a hard stenosis, it's some air in the balloon. So once again. So it opened up properly, have six atmospheres on the deep femoral.
I think the advantage of doing it sequential is also that you don't have the risk of overinflating the common femoral artery.
Yes, that's absolutely the point. Because when I have a 5 and a 4 millimeter, in summary, it's a 9 millimeter, it could be harmful for the vessel wall. But we will see now in a few seconds what is the result. Perhaps it works. We expected that. So, nochmal ganz still liegen, wird warm. So, okay, what do you say? It's a proper flow. This was prior to the PDA. We have, take a look at this segment here. And this is after the dilatation. Okay.
So the profunder hasn't really improved.
Yes.
Looks about the same.
I mean, the SFA
Yes.
is so and so, yeah.
Yeah, it's about the same.
Well, as you already mentioned,
it's quite the same.
this can be fixed in a second step, either surgical or you go in with a bigger sheath and go in with some atherectomy or whatever. If really indicated, I would proceed now with the popliteal to fix this outflow problem.
Yes. So we go to the next lesion, and I switched off the 14 balloon. Kannst du mal den Draht schieben, 14er? 14er, ja. So, only to have it in, okay, have it in charge if we need it. So, ich brauche jetzt den kurzen 5er. Den Armada 35 kann man nehmen. So now, the guide wire is still in place, as you can see. And we take a short angiogram to have the lesion exactly. And I decide to, because it's not quite clear, we can use up to 3 sirolimus balloons. I would say this is a rather short lesion in the distal SFA, to treat this primarily with a POBA and to fix then the problem in the popliteal artery. Let's see if it works. So, okay.
Sag mal,
Okay. here. I think it was here, we can prove it immediately. So, wird noch mal warm, bitte ganz still liegen.
Ja, sag mir mal kurz.
Oh. Okay, a little bit more distal. Okay, good. So, and look how it responds to the dilatation. So a little calcification is to be seen carefully, but it promptly responds. Yes, we have 6 atmospheres. Let's open up promptly. So, okay. I hope we have enough time to see, can show you the restoration of the popliteal artery. Wir brauchen dann den 4 mm Prober. Nochmal. Den machen wir runter, dann spülst du mal durch. Yes. Ja. So. Gut. Das lege ich mal hier hin.
Okay.
So, okay.
Das anbietet, schalten wir dann rüber, ne?
Inflation time was quite a minute. So, okay.
Why are you not using this balloon now also for pre-dilating the popliteal artery?
I'm afraid it is with 5 mm a little bit too large. And what I'm trying to avoid is a bailout standing in that area. So this looks fine, I guess. And as you can see now, when we open up this short segment, we have a prompt flow now also in the popliteal. And this is quite as we expected, that not such a long lesion. So, Dr. Zeller, I understand, but we will see. I can try this to inflate this not too much to save balloons, yeah. But I'm afraid it's a little bit too much when we see this tiny segment in P3 immediately at the origin of the anterior tibial. I feel more comfortable with a 4 mm.
That's reasonable.
Yes, do you agree?
No, not really, because
no,
the biggest mistake done in the past was to undersize balloons. Yeah. This is not only true for DCB, but also for plain balloon. So if you do not fully disrupt the plaque, you will see recoil, you will see dissections. The outcome is inferior. It has clearly been shown in the Levant 2 study, where the operators had been reluctant in going into the lesion with an adequately sized balloon. So the balloon to vessel ratio was too small, and the outcome was much inferior as compared to a proper sized balloon to vessel ratio. So, and to be honest, I never perforated a male popliteal artery with a 5 mm balloon. So that's almost impossible.
Yes. No, never say impossible, but
almost.
we don't. This almost okay. This is not our primary goal. What I try to do is I can take the 5 mm balloon, and let's see what happens. We don't have to inflate it till the maximum. You're absolutely right, and if it works, it will be great. We save time and balloon. So, okay. So here's the balloon. It's the 5 mm from before, so it works. So you can see there's a little resistance. So okay, this is the origin of the anterior tibial artery, and I think we can go a few millimeters, because if the surgeons have to solve this problem, they do a crural bypass. They will never use the P3 segment after we are working here. So, and it fits well. So we can see right now. So, kann ein bisschen drücken, ne? We do this very gentle. We have 4 atmospheres. I will deflate again to have not the bubbles. And do it, repeat it now. Okay. So, dann brauchen wir noch mal den gleichen Sirolimus, den wir eben hatten. Ja, wir den haben noch mal den 520, wenn wir. Ja. So, okay. I guess this is a bubble distally in the balloon. It's not really a lesion. Alles gut? Keine Schmerzen? So we have 6 atmospheres. I don't want to overdilate, as you can imagine. And now we look at the result of the first POBA with 5 millimeters and 6 atmospheres. Bitte? Ja. Ach hier, gut. Okay. So, wird noch mal warm. Bitte ganz still liegen. So, I think you're absolutely right, Professor Seller. We didn't have over-dilated, and what we can see is a patent outflow now through the anterior tibial. We will fix perhaps a problem with peroneal, and we have a slight dissection, I guess. But we, in the second step, we will now performing the next Sirolimus balloon. And then let's see how it works after an additional inflation.
So what size of Sirolimus Magic Touch balloon are you going to use here? Again, a 5?
Also a 5 millimeter, yes.
Okay, and you're going to take it up to
5 millimeter.
To 6 or more atmospheres here?
Let's see how it works, how it inflates, but it should inflate proper. And I go primarily to 6 atmospheres for 2 minutes, and then have a control angio, and then decide if we go a little bit more than 6 atmospheres to fix, perhaps when it is still there, the dissection. Otherwise, we can think about to have a bailout stenting with a supera, let's say, in this area. We have good experience with that stent in this location, but we try to avoid a stenting in that area. So, this is the Sirolimus balloon again. Absolutely comfortable with like any other balloon, so there are no differences. So now we place it as in the same manner as before, even at the point of the bifurcation, and then dilatate it again for 2 minutes at 6 atmospheres. So, okay, kann noch mal drücken, ja? So, it deflates proper. So, once again, back. So we have 4. I hope you can see this. Turn a little bit. I look in the monitor, and you can see it.
So is this balloon?
Do you want to go any further for this?
Is this balloon also semi-compliant?
I guess it is.
Yeah. Personally, I must say, I would take it to higher pressure because it's still not open in the proximal part. So, I mean, if it would be a Paclitaxel balloon, I would take it to 8 or 10. But I mean, I don't know.
Yes. I mean, I don't know. Yes.
I would say it's independent.
Okay.
It's coated with Paclitaxel or uncoated.
Yes.
Or with
just for mechanical reasons.
You need proper angioplasty result first.
You have ones to disrupt.
But as you see, when we give the vessel a little time, it's 6 atmospheres as well. But as you can see at this little nose here and here, it opens up slowly over time. And we have always to elevate by small steps to reach the 6 atmospheres.
All right.
Because
That's absolutely
forget
correct,
it's
to
a calcified
increase the
vessel.
pressure slowly. But at the end, finally, you need to achieve a fully expanded balloon shape. Otherwise, you will face relative early recoil forces, and you will have early
Alles gut?
restenosis. That's the problem here.
Yes, yes.
Okay. Actually, what we would like to propose, maybe we can leave you for a little bit here so that you optimize this still a little bit fast, because the cath lab in Leipzig is also ready. And we come back in about, it's probably going to be in about 15 minutes to be realistic. Is that okay from your workflow, or?
That is okay for our workflow. We can show then on the live screen the results of the intervention. Yes, absolutely okay. Thank
Okay,
you.
perfect. So thanks so far, and let's switch to Leipzig. So, gentlemen, Sven and I assume it's Johannes, yeah?
Yes, hello.
Hello, good afternoon, Dirk, and to everybody. Yeah, Johannes is with me, and he is happy to introduce the case.
I could only tell from the height.
Okay, yeah. We are here with a male patient with an occlusion of the left anterior tibial artery, 79-year-old. Some ulcerations at the forefoot and severe claudication, and there was an intervention in the last December where we ballooned the peroneal artery, which is unfortunately it's re-occluded in between. So next slide, please. Typical risk factors: arterial hypertension, diabetes, and hyperlipidemia. Next slide, you can see the pre-angiography with the occlusion of the tibial anterior and the mid-distal portion, and here the peroneal artery is quite good. At the foot, relatively rare side branches. So next slide. So we are in an antegrade approach with the 6 French 55 centimeter sheath, and first we try to get into the occlusion from antegrade. We had then to change for retrograde, puncture side of the dorsalis pedis, and then strategy was to balloon with a normal balloon, and then with the DCB, Sirolimus coated balloon. And if there is some dissection, then maybe implant some TECs. Okay, maybe Sven can show you the work until right now.
Yeah, thank you very much, Johannes. So this science behind the Sirolimus eluting balloons here you had already discussed in this session. This is our BTK case here. The left side, you can see here the recently recanalized tibioperoneal trunk is re-occluded already. So actually occlusion of all BTK arteries in this patient, and because of his severe symptoms now, also with this small ulceration on the toes, we decided this should be, the anterior tibial artery should be the target here. However, if you look at the foot level, a very poor runoff actually distal to the malleolus, actually very small arteries only. So what we tried is first, of course, in an antegrade fashion, here with 014 guide wires to cross the occlusion from antegrade. However, after long attempts and several attempts with different guide wires, CTO guide wires, was definitely not possible to cross in the distal anterior tibial artery. It's not so calcified, but very fibrotic occlusion, so nothing could go down, no guide wire, no support catheter. And in this case, it's relatively fast and switched to retrograde puncture, like in this case here, we punctured the dorsalis pedis artery here under fluoroscopic control. And we're able then to advance the guide wire from retrograde through the occlusion here. You see it's not so calcified, but very fibrotic, very hard occlusion anyway. And also with the normal shape of the guide wire, we could not cross. Also here we had to create a loop. And eventually then the loop went through here. You see then the loop is moving freely. So that's always the sign that we then reached the compartment from antegrade where we did already a predilatation. So then guide wire was snared as usual using 4 French diagnostic catheter here. And then we did the ballooning, predilatation actually with a POBA of the entire occlusion down from the proximal anterior tibial down to the dorsalis pedis. And this is here the intermediate result after predilatation. Already nicely opened artery actually, more distally. Some recoil, some dissection maybe. This is the area also where we had the problems to cross with the guide wire. And at least we connected to one of the foot arteries here. And then we tried also to connect a little bit more distally. You can see this in an AP view. There is actually also an occlusion of the dorsalis pedis artery. This is all collaterals here. And we tried to advance the guide wire a little bit more distally and ballooned also more distally. You can see here there's another spot where the balloon could not open completely. Very rigid occlusion. So that's why we also switched to scoring balloon. That's a vascutrac. Also the vascutrac did not immediately open completely. So what we would like to do in this case is we do repeat angioplasty, move the balloon a little bit, repeat angioplasty. Also with the shoulder of the balloon, this sometimes also helps to apply a little bit more force to the spot. And then eventually, so we decided to go further on as planned with DCB, with a magic touch balloon. As you can see here now, the distal spot, the distal marker of the balloon now could open completely. So I think this was the result of the repeat PTA with the scoring balloon. The DCB now is fully open. It's a magic touch 2.5 diameter, length 15 centimeter, followed by the proximal balloon. This is 3.0 by 200 millimeter magic touch balloon. Yeah, this is the situation where we are right now. So we just finished ballooning with magic touch with this DCB. And this is our angiography after the DCB, proximal part. Very brisk flow already, so I would say that's acceptable. More distally, we see still, maybe some dissection there, some recoil. However, if you look at the foot arteries, still reduced distal appearance. I mean, nevertheless, I think at least one plantar branch is filling now much better. And this is the result here after 2 DCBs, after recanalization of the anterior tibial artery, something we could discuss now with you. Dirk, what do you think about?
Well, that's a nice piece of work so far. Yeah, I think very elegant retrograde crossing. Could you just, because the balloon technology is a little bit in the focus, of course, of this symposium. So just explain us again, how do you size in these vessels the predilatation balloon and the eventual, the final DCB? And do you expect any differences here? Probably not, I assume, between a paclitaxel or a Sirolimus eluting balloon. But how do you do the sizing?
Yeah, of course, we have only limited experience with Sirolimus eluting balloons. So I think it's the same principle of drug uptake from the balloon to the arterial wall. I also believe that it's very important first to have some kind of vessel preparation, good predilatation, for example, and also good contact of the drug-coated balloon with the arterial wall, and also a sufficiently long contact with the arterial wall. So I size my predilatations one-to-one to the reference vessel diameter, and I try to oversize the drug-coated balloon, I mean, from an angiographic appearance of diameter a little bit. So that's why, maybe we can even postulate distally with 2.5 millimeter balloons. However, this patient had already remarkable pain at 2.5 millimeter balloons. That's why I decided for the distal portion of the artery also go with a 2.5 drug-coated balloon. I use a little bit higher pressures, as we know it for Paclitaxel eluting balloons. The higher pressure leads to better patency. Rated burst pressure here of this balloon for the BTK application is 12 atmospheres, and that's why I used it also at 12 atmospheres. This is definitely a semi-compliant balloon. If I look at the compliance chart, 2.5 at 12 means 2.72 millimeter of diameter of the balloon. So I think that's an appropriate diameter in this area.
Any other comments?
Sven, why do you think that the initial angioplasty went down? This is a relatively early restenosis or reocclusion. Was that properly sized at the time or not?
Yeah, if I looked honestly at the angioplasty result, it was also some dissection visible actually in the trunk. It was a little bit undersized, maybe the balloon. Maybe for the tibioperoneal trunk we can implant, if we see a dissection and we have a patient with CLI, we could use coronary trunk-eluting stents in this location. So probably I would have treated this artery at the first attempt a little bit differently to achieve better patency. Nevertheless, this patient has small arteries here below the knee, and that's why was also our thinking maybe he can benefit then more from drug-coated technology in order to keep it longer open if we recanalize now the other artery.
So if you take this a little bit away from what you've done so far, just to discuss, whether this is good enough or whether there is any room or need for optimization of your procedure. I mean, clearly we see still the perfusion of the forefoot is somehow limited. So that's more a question here also to the panel. So when would you consider doing more in the plantar loop? Or, I mean, we could see that it was very difficult, if so far quite almost impossible to go further. But maybe with more effort, there is it would be doable. The question is it needed? When would we do that?
I think I would perform a more distal angiography to see whether there is actually a pedal plantar loop that you can recreate. I think the proximal part looks perfect, but with a lack of outflow, I have a fear that it will occlude again. So I would try to optimize. We see much more plantar circulation now, but I think there is still the distal part of the dorsalis pedis that connects to the superficial arch that is missing. And that probably will lead to a better patency.
There's also this stenosis right at the end of where you ballooned with the drug-coated balloon. Do you see vasospasm? Early on in our paclitaxel balloon experience, we sometimes saw vasospasm. Is that something we see with the sirolimus balloon, or is that just persistent stenosis, or it's undilated or underdilated? What do you think about that? And is that limiting your outflow?
Well, I personally believe that is the area where he struggled with expanding the balloon, so the proximal dorsalis pedis segment, which is still stenotic here. This is the area which was initially not really responsive to balloon angioplasty, and that's the key question. How does the vessel look like there? Is it calcified, or is it only fibrotic? Because on the long run, I believe you need to do something in order to improve the outflow to the forefoot via the dorsalis pedis. And atherectomy would be an option. If this would be calcified, then it would be an indication for the stealth catheter. Probably not now, but at least in a shorter time period.
So Sven, tell us, what are your plans?
Yeah, I agree actually with the panel. I think the remaining stenosis distally, I mean, this is very subject to be the spot for reocclusion or restenosis in the very near future. There was actually no real foot loop visible at the baseline angiography. I mean, I can inject now into this balloon once again. I can pull out a wire, check it again, do a very selective angiography here distally. Yeah.
I believe in your last angiogram in the late phase, we could nicely see that the extent of the dorsalis pedis is going down really to the direction of the foot arch, and even if it's not closed, it would be valuable if you could really fix this focal proximal dorsalis pedis lesion in some way. And the key question is what kind of atherectomy device might help here. Is it, in case of calcium, it would be high-speed orbital atherectomy. If it would be more fibrotic, it could be the Phoenix catheter, which might be helpful here.
Yeah, okay. I think, Sven, we don't want to push you here too far. We can see you're trying to redilate this distal edge where the opening was incomplete. I think otherwise, I think it's clear it's not easy to make here a good decision. Being too aggressive in the plantar arch is also many times not a good idea. So it really has to be decided from case to case here. And also spasm, of course, is an issue here, whatever you do there. So I think for now we would like to leave you. I think it was a great demonstration and excellent tibial recognition so far with a very good result. And certainly a good indication for a drug-eluting device. So let's hope that this sirolimus eluting balloon is doing its job here in this challenging patient. So thank you very much. I think we switch back quickly to Jena. So Dr. Aschenbach,
Yes.
Yeah.
So what happened in the meanwhile?
Give us the quick summary in 2 minutes, I would say, yeah?
Yes, absolutely. I don't need 2 minutes. So we have dilated again and again, as say 2 sessions with prolongated dilatation. And we have still one problem you can see here.
Can we get the angiogram on the screen? Currently, we see your patient registration sheath.
Is it live screen? The live screen online?
Yeah, it's
yes.
It's something covering the angiographic image. It's
macht ihr mal zu?
Yeah.
Okay, now you can see it.
There we go.
Yes, you can see the problem. A short wire injury in the peritoneal trunk. And this is the result after repeated inflation. So we decide to implant or to perform bailout stenting. We have implanted a supera stent. And I'll show you the result. So, where is the image? So, okay. A lot of images. So that is the final angiogram from the proximal side. I think it's, for these circumstances, a good result. But he will profit definitely from a patch, I'm sure. And this is the lower lesion. And then we have the popliteal trunk. You can see here. And then we fix the problem with this tiny little bleeding in the meanwhile. So that's our final result.
Great, thank you very much. I think it's a very nice demonstration and very nice recognition result here. Thank you.
Okay.
Great. Next, to close the session, I'd like to invite Dr. Shiner to talk about Sirona, head-to-head comparison of sirolimus versus paclitaxel drug-eluting balloons for fempop artery.
Yeah, thank you very much. So yeah, we've seen interesting cases. Unfortunately, the actual drug penetration cannot be visualized here during the live transmission. So what's really exciting is the science and the options we have here to really advance the field. And so one of the studies which we are planning here in our region is the so-called Sirona study, which is going to be a head-to-head comparison of the sirolimus-eluting paclitaxel balloon compared of the sirolimus-eluting balloon compared to a paclitaxel eluting balloon. So clearly the study objective here is to investigate the safety and efficacy of this sirolimus DCB in direct comparison to the established paclitaxel eluting DCBs which are currently on the market. And the study is going to be performed in Germany in several centers, and we are going to focus on symptomatic femoral popliteal artery disease. The study design, it's going to be a prospective, multi-center, one-to-one randomized study. We are planning, as we have done that in several other previous studies, to implement a stratification according to the lesion lengths into 3 groups, 1/3 of the patients in a short group up to 10 centimeters, 1/3 medium length lesion 10 to 20, and also 1/3 with long lesions. So that's really an attempt to make sure that this is a clinically relevant study, including also a sufficient number of real-world patients with longer and more complex lesions to really get immediate feedback here for our clinical procedures. The study population, which is based on a non-inferiority power calculation, is going to be 478 patients, 239 per study arm, which are, of course, symptomatic patients. So that's the preliminary list of the participating centers, as said, in Germany, and also 2 centers in Austria. But that's, let's say, not necessarily the final list, so there are probably still options for centers who are highly interested also to apply and to consider a participation. Study endpoints, in terms of primary efficacy measures, we are going to assess the patency rate in a typical manner as freedom from clinically driven target lesional vascularization, or freedom from duplex ultrasound-based binary restenosis using a PSVR threshold of 2.4. The safety will be assessed with a composite endpoint as done in many other trials: freedom from all-cause death, freedom from target limb amputation, and freedom from target vessel revascularization out to 12 months. And then, of course, there will be a number of secondary endpoints. Very importantly, we are also going to look thoroughly on the clinical improvement with walking impairment questionnaire and a 6-minute walk test, and a subgroup of patients potentially also with a treadmill testing. What about the inclusion and exclusion criteria? Rutherford 2 to 4 patients will be enrolled. De novo lesions and restenotic lesions without a prior implanted stent. Lesion lengths, as I mentioned, up to 30 centimeters. And the exclusion criteria also pretty standard. Of course, patients with very severe calcification, which are not suitable for a balloon treatment, will not be included, as well as patients which have to undergo or had already undergone major amputation, previous bypass surgery, and so on. So the follow-up is planned to be conducted over a total observation period of 5 years. And at the 6, 12, and 24 months time point, we will have clinical visits with duplex ultrasound measurements which will be eventually assessed by core labs, and the whole study will be fully monitored. So this again is an overview of all these study procedures and their respective time points. I don't want to go into that in detail. Here's the randomization again displayed with the 3 strata for each randomization arm. So I think certainly an exciting study. It's no question sirolimus eluting devices have a lot of interest and a lot of promise for the future. I think it's very exciting to run this head-to-head trial. Thank you very much.
Thank you, Dr. Scheiner. And I think with that, the hour is drawing to a close, and I'd like to thank all of our participants and move on to the next session. Thanks very much.